Today we will study about the glomerular diseases, the pathology of glomerular diseases. In this session, we will study about the nephritic syndrome, nephrotic syndrome, post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, Goodpasture syndrome, membranous nephropathy, focal segmental glomerulosclerosis, and a membranoproliferative glomerulonephritis, IgA nephropathy, chronic glomerulonephritis, diabetic nephropathy, and nephroblastoma or Wilms tumor. So, we will study about the etiology, pathogenesis, clinical features, morphology, microscopy, and diagrams of these glomerular diseases. So, these are the topic to be covered in this session. So, we'll move on to glomerular diseases classification. So, in classification, we have primary glomerular nephritis or glomerulopathies, and then we have secondary glomerular diseases and hereditary disorders. In primary glomerular diseases or primary glomerulonephritis, so the kidney is the only or predominant organ involved. So, in this, we have acute proliferative glomerulonephritis. It is also called as post-infective or post-infectious glomerulonephritis, post-streptococcal glomerulonephritis. Okay, then we have rapidly progressive glomerulonephritis. It is also called as crescentic glomerulonephritis. And then we have minimal change disease. And next one is proliferative glomerulonephritis, and we have membranous glomerulonephritis, C3 glomerulonephritis, dense deposit disease, focal segmental glomerulosclerosis, IgA nephropathy, and chronic glomerulonephritis. In secondary glomerular diseases, in these disorders, the glomeruli are involved secondary to a systemic disease. So we have SLE, diabetes mellitus, vasculitis, amyloidosis, Goodpasture syndrome, bacterial endocarditis. In hereditary disorders, we have Alport syndrome, thin basement membrane disease, and Fabry's disease. So, this glomerulopathies or glomerulonephritis, these may show one or more of the three basic histological changes. So, these diseases shows histological changes, either one or more of these three basic histological changes. So, the first histological changes is increased cellularity or hypercellularity. So, there is an increase in the number of cells in glomerular tufts. Such lesions are called as proliferative glomerulonephritis. So, it may be due to, so there is increase in the cell number, right? Yes, or hypercellularity occurs. This may be due to cellular proliferation, that it may involve any part of the cell, endothelial, mesangial, or epithelial cells. Then we have leukocyte infiltration. It may be due to the leukocyte infiltration, that is, it may be due to the infiltration of neutrophils, monocyte, or lymphocytes, and formation of crescents. So that is, these are formed due to the proliferation of parietal epithelial cells and infiltration by leukocyte. So why this happens? This is due to this develops as a response to fibrin. Fibrin leaks into the urinary space through the ruptured basement membrane. There is a rupture in the basement membrane. So what happens is that this fibrin leaks into the urinary spaces. So then there is a proliferation on the parietal epithelial cells, and thus the formation of crescents occur. So then the next histological alteration is basement membrane thickening. It is mainly seen in diabetic glomerulosclerosis. So this is due to the deposition of amorphous electron-dense material, that is mainly immune complexes. It may be on endothelial epithelial side of the basement membrane, that is subendothelial or subepithelial, or within the glomerular basement membrane. So that is the second histological alteration, that is thickening of the glomerular basement membrane. And then we have the last histological alteration, that is hyalinosis and sclerosis. So what is hyalinosis? It is the accumulation of homogeneous and eosinophilic material in the glomeruli. It consists of plasma proteins that have leaked from the circulation into the glomerular structures. This is due to endothelial or capillary wall injury. So hyalinosis is just the accumulation of homogeneous or eosinophilic material in the glomeruli. And what is sclerosis? It is the accumulation of of extracellular collagenous matrix either in the mesenterium, that is example is diabetic glomerulosclerosis, or in the capillary loops, or both, that is the accumulation of extracellular collagenous matrix. Hyalinosis is the accumulation of homogeneous eosinophilic material. So these are the three alterations which is seen in these glomerular diseases, that is increased cellularity, basement membrane thickening, and also hyalinosis and sclerosis. So classification, I guess you remember the classification. There is primary, secondary, and hereditary disorders. And then we will move on to the terms. So there are specific terms. The first term is diffuse or generalized. These means that a lesion affecting or involving all the glomeruli in the kidney. And what does global means? Global means it involves the whole or entire individual glomeruli. And what is focal? Focal is a lesion involving only some portion of the glomeruli in the kidney and leaving others unaffected. So it will be having unaffected portion and affected portion. What is segmental? It involves a segment of each glomeruli. And capillary loop or mesangial, affecting predominantly capillary or mesangial region. Okay. Then we'll go on to the pathogenesis, the common pathogenesis in all glomerular diseases. Okay, next we will move on to the pathogenesis. Pathogenesis of glomerular injury. So this is mainly immune mechanisms, okay, and various immune mechanisms involved in glomerular injury. The first one is antibody mediated injury. The second one, it may be due to the cell mediated immune injury, or it may be due to the activation of alternative complement pathway. So the first one, antibody mediated injury. So in situ immune complex deposition or circulatory immune complex deposition. So circulating, there is antigen due to any infection or any other responses. There is antigen and antibody complex will be formed in the blood. Okay, so there is circulating immune complexes which gets deposited in the kidney. Okay, this get deposited in the kidney. So it may be due to exogenous antigens, that is infectious products, or it due to endogenous antigens, that is DNA, tumor antigens, etc. And in situ immune complex deposition, that is fixed intrinsic tissue antigens are there, or planted antigens are there. Example, that is anti-glomerular basement membrane nephritis. Here we have exogenous and endogenous infectious agents. In exogenous, endogenous, it may be due to DNA or nuclear proteins. And the second one is due to cell mediated immune injury, or the third one is due to activation of alternative complement pathway. So we will look antibody mediated injury in detail. So it may be due to the deposition of circulating immune complexes. Okay. So this is antigen, this antigen antibody complex is formed here, and it may get deposited on the subepithelial surface, that is outside at outer surface of the glomerular basement membrane, and it may get deposited in the mesenterium, or it may get deposited on the subendothelial, that is at inner surface of the glomerular basement membrane. So this is the glomerular basement membrane. So this is the epithelium, and this is the epithelial surface. This is the podocytes of visceral epithelial cells, and we have, this is the endothelial surface. So the immune complexes, subepithelial deposits, that is this is the glomerular basement membrane, and this is the epithelium. So this is immune complexes get deposited over here, that is outside the surface of glomerular basement membrane, or it may get deposited in the mesenterium, or it may get deposited in the inner surface of glomerular basement membrane. These are the immune complexes. So all these further shows granular immunofluorescence. Okay, so example of these deposits, that is example of this is IgA nephropathy, lupus nephritis, and post-infectious glomerulonephritis. And next one is in situ binding of antibodies with or without immune complex formation, that is with or without immune complex formation. The first one is antibody against antigens on podocyte. In podocyte there are certain antigens, so antibodies are generated against antigens on the podocyte. So subepithelial immune complex deposition occurs over here, and it will contribute to the granular immunofluorescence. Example is membranous nephropathy. Or what happens, antibody against the planted antigens, example SLE. So some antigens may not be present normally, present in the glomerulus but are planted to the glomeruli. It may interact with the various intrinsic components of glomerulus. So that is the breakdown apoptotic cells in SLE is an example that accumulates in the mesenterium. And the third one is anti-glomerular basement membrane antibodies. That is, antibodies are formed against the glomerular basement membrane itself. Example is Goodpasture syndrome. Goodpasture syndrome is the example. It has an experimental counterpart that is here, and then no immune complex formation occurs over here, so we get a linear immunofluorescence. So in all these cases, that is 1, 2, here also we'll get a granular immunofluorescence, but only this anti-glomerular basement membrane antibodies will get a linear immunofluorescence. Next, we'll move on to the morphology. So I guess you remember that we have discussed about the histological variations. Histological variations that we have discussed earlier. The first one was hypercellularity, and the hypercellularity was due to the three causes. That is, the first one was the proliferation, the second one was due to the infiltration. Okay, so the here the involved glomeruli shows the leukocyte infiltration. Okay, and variable proliferation of the mesangial and the parietal epithelial cells. If the immune complexes are deposited, so there is antigen antibody reaction and immune complexes are formed, and these get deposited in the subendothelial or the subepithelial surface. If it is get depositing in the subendothelial surface, it shows infiltration of the leukocyte and also the proliferation of the glomerular resident cells. And if it get deposited in the subepithelial surface, it is free of inflammation. Example, primary membranous nephropathy. That is all about morphology. Now we are going to study about the mechanism. So, antibodies are produced against the antigen. It may be due to the intrinsic antigen or it is due to exogenous antigens. Antibodies are produced. So, antigen antibody complexes are formed. That is, immune complexes are formed in the circulation. Yes, it gets trapped in the glomeruli, and this produces an injury by activating the complement and recruiting the leukocyte. So, there is a binding of the immune complexes to the Fc region on the leukocyte, and it stimulates the cell injury. So, here are the glomerular diseases caused by the complement activation. It includes the dense deposit disease, C3 glomerulonephritis, complement-mediated thrombocytopenic thrombotic microangiopathy, and also atypical hemolytic uremic syndrome. So the first two are the primary diseases, glomerular diseases, and the last two are the systemic diseases. So these may be due to the unregulated activation of the alternative complement pathway, or it may be due to the acquired autoantibodies against the complement components, or it may be due to the inherited abnormalities of the complementary regulatory proteins.